what I mean is things like Coccivera, Coxavalgo, Antiversion Retroversion, right? Some of these terms that you may have already read about, okay? So the first one that I want to cover is going to be Coccivera. Okay, now Coccivera, first thing we really need to understand is what the appropriate angle should be after I turn that on. You guys can set something. Were you guys waiting for me when I was?
You're on a roll. We don't want to interrupt.
Oh, come on. When am I ever rolling?
PowerPoint definitely works.
The missing PowerPoint?
Still have the same.
Yeah, it should be the same PowerPoint. All right, so give that a second. All right, so what we should have ideally is a 125-degree angle between the femoral neck and the femoral shaft. So I'll wait 1 second. Boom, there we go. Is that better? Good. So the ideal angle between the femoral neck and the femoral shaft should be about 125 degrees. At 125 degrees, what we're going to see is we're going to see a very equalized load between the femoral neck and the femoral head as it articulates with the acetabulum. Where this is going to get a little more difficult is when we start talking about some of these deformities. So, second picture here, what that is displaying is something called Coccivera. So what Coccivera is a femoral neck / shaft angle of less than 125 degrees. Now, the reason that becomes important is a couple different reasons. Number one is we're going to see a different load pattern happening. Remember, like I said last week, one of the more difficult things about the lower extremity is this concept of weight bearing, right? So weight bearing is definitely going to play into a lot of what we see with some of these deformities. So with Coccivera, one big thing I'm going to see is I'm actually going to have an increased moment arm, little biomechanics for you guys, with the hip abductors. This is actually going to allow my hip abductors to be more effective. Now, what do I mean by more effective? What I mean about more effective is that I can, more effective, basically more efficient, I can get more bang for my buck, okay? This is where moment arms come in. So let's think about this, okay? Best example I can come up with off the top of my head is a door. All right, so look at the doors around the room. Where's the hinge versus where's the handle? As far away as possible. Why is that? Because it makes it the easiest job, right? So one thing I'll challenge you guys to do after class is push the door open from the very edge, the farthest away from the hinges, and then move into the middle and try to push it and see how much force you need to push it by. What you're going to find is going to be a lot more force. And then go right next to the hinges and try to push it. And it's going to be almost impossible because the larger moment arm means that I'm actually going to have more of a lever arm to work with. Means that I have to provide less torque aka the muscle has to do less work to get the same result. Okay, so with Coccivera, I'm going to have an increased effectiveness of my hip abductors. That is going to become huge when I start seeing patients with total hip replacements with some of these other deformities that I'm going to see. Now, the bad thing, or the bad things, I should say, about Coccivera is that we're actually going to have a decreased load on the femoral head, which sounds all fine and good, right? Decreased load, less shear forces, less strain, not a bad idea. The problem is that with Coccivera, I'm going to have increased load on the femoral neck. This becomes a huge issue because what are patients going to be susceptible to if they fall? Hip fracture, right. Also, let's think about this, and I've actually seen this a couple times in my career. Young athletes, 12, 13 years old. Hey, Jimmy's showing some talent. Let's get him in the weight room. Let's load him up, and let's start doing some squats. Jimmy's femoral neck, because nobody really knows he has a Coccivera deformity, then goes through more change, increased load, and actually has an increased risk of hip fracture. Okay, because of this underlying, most of the time, genetic condition. Okay, so Coccivera, less than 125 degrees. Hip abductors, more effective. Decreased load on the femoral head, increased load on the femoral neck. But these patients are more susceptible to femoral neck fractures. Okay? On the other end of the spectrum is going to be something called Coxavalgo. Coxavalga is going to mean more than, what is going on here? More than 125 degrees between the femoral neck and the femoral shaft. So this picture down here, this third picture, is a picture of a Coxavalga angle. Now, one thing that's going to get a little confusing as we start moving down the lower extremity is we're going to see Coccivera, Coxavalga. We're also going to see Genuvera, Genuvalga, right? And genu just means knee. And what we're actually going to see is that the two are going to play off of each other. So one thing to really kind of think about and start thinking about is, and we're going to see this throughout this entire rest of the course, what happens at one segment of that chain will have an effect through the other segments of the chain, all the way down to overpronation, if you guys are familiar with that term, or supination, if you guys are familiar with that term. So a lot of times what we'll see is my patient's gait cycle, even though I see it at the foot, or see a deformity at the foot, to be more specific, it's actually something happening at the knee or happening at the hip that's causing that deformity. So that's one thing you guys are going to have to do as physical therapists is study that entire cycle. So Coxavalga, like I said, over 125 degrees of angle, decreased hip abductor effectiveness. Makes sense. Lower moment arm, decreased effectiveness. AKA my hip abductors, gluteus medius, gluteus minimus, have to produce more EMG activity. They have to get more active. They have to do more work to produce the same effect. AKA their hand is closer to the hinges on the door, not farther away. Okay. I'm going to have an increased load on the femoral head. So what we're going to see here is that because my femur, in terms of my femoral neck and femoral shaft, is more vertically oriented, right? Does that make sense? That I'm actually going to have more translatory force being put through the neck and in through the head of the femur. So what we're going to see is the femoral neck is going to be under decreased load, but the femoral head is going to be under increased load. So decreased load at the femoral neck. What we're going to see clinically is that these patients will have a decreased likelihood of a femoral neck fracture. However, if we think about it, if I have increased forces happening at the femoral head, and I have more impaction happening between the acetabulum and the femoral head, what are some diagnoses that I may be more susceptible to? Say it loud. Labral tear would be one. Arthritis would be another one. Dislocation, kind of, sort of. There's a lot of other factors that play into that one. Yeah, but not a bad thought at all. Something else? I'm sorry? Not necessarily. Not necessarily, because what we're going to learn next year in medical screening / imaging, I can see some real messed up images, and that person has 0 out of 10 pain. So there's not necessarily a correlation between pain. Now, you guys just talked about pain today in MSK1, right? There's not a ton of correlation between clinical findings and the pain that someone's experiencing, right? And I always give the example, and this is where arthritis comes in, and I think you make a really good point. People will ask, how did I get this way, right? How did I get to this arthritic state? I don't feel a thing. And the example I give them is, do you feel your hair grow? No. Why don't you feel your hair grow? Because it's so slow. It's so gradual. Now, if I went up to, and I'm just going to pick on you for a second, Gary, and I took his hair and went and did like everything to the left, you would feel that, wouldn't you? Because it's a big change over a short amount of time. Okay. So little change over a long amount of time, you can adapt to those things, right? You're not going to necessarily feel those things until they hit a certain threshold. That's why that patient that comes in and it's like, holy cow, I got arthritis when I was 66. No, you probably got arthritis when you're like 21, and it just got progressively worse over the next 45 years or whatever. Okay, so be very careful with that. So Coccivera, Coxavalgo, very important to remember, not only in the context of this unit, but as we start building, we're going to start building on how Coccivera and Coxavalgo are going to affect things like Genuvera, Genuvalgum. Okay, there's going to be a lot of different changes that are going to happen. Not necessarily, because let me ask you this. Have you ever seen somebody that is bow-legged? Okay. Do you notice that? Right? And I'm not trying to pick on you, but that's my point, is you have to kind of define what notice means. Right? So I mean, you guys watch me walk, and we're going to get into actually in the next slide here why I walk the way I walk. Because what you're going to see is that depending on torsion angles, that's going to affect how my toes actually interface with the ground. Okay, so I notice it. You notice it. Does it affect me? That's debatable. You know, so you have to really, and this is where we kind of have gotten out of, and you guys are in a really good area of healthcare right now, and you guys are coming out of school in a really good time, because when I came out of school, we were very steeped in the biomedical model, which means that if there is a clinical finding, we have to treat it. So I used to get diagnoses all the time for anterior head displacement. What does that mean? Anterior head displacement, right? Poor posture. So we would try to fix all these people's posture, and be quite honest with you, it was a very poor outcome. It's a very poor result. Why? Because that person's been sitting, standing, walking, functioning like that for the last 70 years. I hate to break it to you, but 2 times a week for 4 weeks therapy probably ain't going to do it, right? It's not going to have that much change. Can we have a little change? Maybe. We're going to have a ton of change? Probably not. So we've really kind of moved away from that biomedical model that if there's a clinical finding, we have to go and attack it. And we have to treat it. Okay. All right. So the next big concept, and we kind of saw this at the shoulder, but we're going to go ahead and cover it for the hip as well. You're actually going to see it more prevalent in the hip, is something called antiversion and retroversion. Yeah. For Coxavalgo, arthritis, femoral acetabular impingement syndrome, and labral tears. I think you said labral tears. What's that? Okay, I'm going to say FAI now. So let me write it down for everyone. Femoral acetabular. And remember, that just means hip. Impingement syndrome. So what's being impinged, and this is why I underlined the word syndrome. Do you know what the definition of syndrome is? Somebody say it so I can. It's a collection of signs and symptoms without a defined pathology. That's the problem with syndromes. So and this is the same thing we see with shoulder impingements. There are 11 pain-sensitive structures in the subacromial space. So when somebody has subacromial impingement syndrome, it could be any or any combination of those 11, right? So do the math. Yeah, there could probably be, I don't know, 1,121 right off the top of my head, different types of subacromial impingements. I really don't care because I'm going to treat the findings and I'm going to treat their functional limitations. Same thing with FAI, right? So it could be everything from the round ligament of the hip to the labrum to the synovial lining to the capsule, you name it. Make sense? All right, so with antiversion, okay, what antiversion is going to mean is that we're going to have more than a 25-degree angle to the anterior. This will make more sense here in a second. What we will see is we will see a medial rotation of the hip or the femur. We will have a structurally shorter leg. And we're going to have something called in-toeing, or what's commonly known as pigeon-toeing. So, is anybody pigeon-toed? Who wants to lay on the table and let's see how pigeon-toed you are? Not that much? Who's super duper pigeon-toed? Like who can do a full W sit? A full W sit, like whoop, like sit with their legs out to the side. Can anyone do that? You can? Let's go. All right. So I will apologize. This is going to come off for a second. Lay on the table. Now, here's how you're really going to check how someone is antiverted or retroverted. Okay. If you guys want to get up and like come on over, that's cool. Okay, you guys know how to check anterior internal and external rotation of the hip. All right, so quick review. Internal or external rotation? Okay. Internal or external rotation? Okay. Now, what you're going to watch for is how much rotation they have. Now watch this. I'm not getting any farther than that now. That's about as far as you will go in external rotation. That's a ton of internal rotation. You shouldn't have it. What's normals for internal and external rotation? 45? Okay. I'm going to tell you, she's way past 45 there. But she's not even close to 45 there. She may be, I'm going to eyeball it, maybe 20, 25 of the max. Here, I would call it solid 60. Right? Now, switch me up. It means you're going to check me. Okay. Do you remember the picture that I put up at the very end of fall semester? Yeah. I have to trust you with my parents. All right. My leg's bigger than yours. Okay, now take me in the external rotation. Okay. All right, good. Look at that external rotation. Impressive, right? Round of applause for the external rotation. Yes. Okay. Now take me in the internal. That's crazy, isn't it? Why is that? Because I have retroverted hips. Okay? Thank you. Big round of applause right there. You walk right into that one. So I like doing that because it gives you a really, and apologize that it's not, my voice into the microphone. But I like doing that example because it gives you a really good sense of the difference between anteverted and retroverted. So anteverted, I'm going to see a ton, I'm talking a ton of internal or medial rotation. But I don't see all that much external or lateral rotation. Okay? What we're going to learn is that this is going to have its own problems at the hip, at the knee, at the tibia, at the foot, all the way down to the toes. So anteversion, more than 25 degrees of torsion to the anterior direction, causing excessive medial rotation at the hip, garbage, lateral rotation, and a structurally shorter leg. And that's become very, very important because what you will see sometimes in the clinic is that they're not equal right and left. So you may have one hip that's anteverted and one that's not. What type of problems do you guys think that would cause? Leg length discrepancy. Yeah. A leg length discrepancy is when one leg is longer than the other. I'm sorry? Potential. And the reason I say potential is because sometimes you can't forward cast that or predict it. And I don't try to predict it too much because go based on what you're seeing. Because what you'll see sometimes is that you may have a Trendelenburg gait or they may hip hike. Okay. Or what they may do is compensate by toeing out on the other side. So that way they have a structurally shorter foot in the ventral plane, or the sagittal plane. Makes sense? So I hate to give you that answer. It depends. It depends. So go based on what you see. All right, so that's anteversion. So retroversion is duck walking me. Right now, all you guys are going to watch how I walk. You should have seen it. I used to teach gait and movement analysis with Dr. Fox, and I had the students study my gait. Literally, one of them said, "We're not sure how you walk."
It's like, wow, really? Is it that bad? Like, oh, it's all over the place. So retroversion. Retroversion is going to be less than an 8-degree angle of torsion. So if we think about it, and I'll pause here for a second, I should have a torsion angle of anywhere from 8 degrees to 25 degrees in the ventral direction. That's the sweet spot. That's what I should have, is about anywhere from an 8-degree to a 25-degree angle. If I see less than an 8-degree angle, then that person clinically has a retroverted hip. I'm going to see that lateral rotation or external rotation is going to be, as you guys saw, fantastic. But internal rotation, this is why I was not a professional hacky sack player, is absolutely terrible. What this will lead to, and you guys will see this in my gait patterns and how I stand actually, is something called out towing. So when I stand, and you guys can see this, how do I stand? I stand with one foot almost at a 25 to 30 degree angle to the lateral direction. So I even stand in external rotation. I will be quite honest with you. If I stand like this, I can feel stress on my hips. If I stand with my toes pointed forward, I can feel a lot of stress. I can't stand like this. I have to stand out-toed. And at some point, if you guys ever meet my dad, he's even worse. So then what I need to start thinking about is I need to start thinking about how this is going to affect muscle function. I need to start thinking about how this is going to start affecting what ligaments are loose and what ligaments are taut around the hip. And then as we move forward, I need to start thinking about the ramifications or consequences for what's happening at my hip lower in the chain, at my knee, at my ankle, at my foot. Because what we're going to see is there are a lot of folks out there that have, and I bet if we took x-rays of Brittany's tibias, we would actually see that she has a torsion in her tibias as well. Because what will happen a lot of times is as we develop and as those bones are very soft and malleable, she wants to get her feet forward because that's the most efficient place for them to be. You get the most bang for your buck in the gait cycle. So she will actually have lateral rotation or lateral torsion in her tibias based on the anteversion at her hips. Okay, so we'll see that a lot. Sometimes you do and sometimes you don't. Right, something that's what we call compensated versus uncompensated. Okay, any questions about torsions? Yes. So angle of torsion is actually what's shown here in the pictures. So what it is if you can see, actually, it's the angle of twist of the femoral shaft. Okay, so basically what they do is they take the femur, put it down, and put both condyles of the femur, and you can actually see it. If I put both condyles of the femur down, see how that femur goes up just a little bit? That's the correct angle it should be. If I put both condyles of the femur down on a flat surface, on a retroverted hip, this femoral head would be up off the table. Okay. What I would like to do, this is not something for this semester, but maybe over the summer, I'd like to find a malleable femur, like that you can actually twist and turn and stuff, so you guys could actually see the lines. We have a 3D printer in the building, I just found out, so That might be where I am over the summer. What's that? No, what was that? Nothing? Come on. If you can say it to someone else, you can say it to me. All right. So what we're going to see in terms of hip ligaments is that we're going to have 3 big hip ligaments and we're going to have 1 small little hip ligament. Okay, so what I want to do here is we're going to draw in kind of a hemipelvis, acetabulum, femoral head, femoral neck. Okay, so that's going to be my obturator foramen. This little green area here is going to be my acetabulum. Just to make that picture look not as bad. So what I'm going to see is I'm going to see 3 huge extrinsic ligaments here. Okay, the first one I'm going to see is something called the iliofemoral ligament. So we're going to draw that kind of purple pink color. Now this is another great thing about ligaments. Remember that ligaments are kind of not only say what they are and are what they say, but they're also going to say what they attach. So that's a really nice thing about a lot of these ligaments. So what we're going to see is the iliofemoral ligament is going to come out and it's going to have 2 major bands to it. And the way that Gray's and other textbooks describe the iliofemoral ligament is it is an inverted Y. So the other name that the iliofemoral ligament goes by, and this is not kind of an official name, it's more what we call an eponym. It's called the Y ligament of Bigelow. Why? Because Dr. Bigelow discovered it. Understand that the iliofemoral ligament is going to be located in the anterior compartment. Now, as we know from studying a lot of other ligaments in this course, both last semester and this semester, the job of a ligament is to attach bone to bone, right? Easy. The other job of a ligament is to make sure those bones don't go flying out in outer space, right? We want to check or limit motion. If we think about it, if I have a ligament in the anterior compartment, it's going to check extension, right? Makes sense. So when I extend my hip, I am putting stress or strain on the iliofemoral ligament. What we're going to see is there's going to be some other motions in combination with other motions that are going to stress and strain the other ligaments as well on top of iliofemoral. The second big ligament we're going to see here is going to be something called the pubofemoral. Pubofemoral is going to be mostly in the inferior compartment. So what we're going to see with the pubofemoral is the pubofemoral is going to check. What do you guys think? What's this? Thumbs up? What's that? Bringing it up. What do we call bringing it up? Hip hiking? Where does hip hiking occur at? Is that a hip motion or is that a pelvis motion? Pelvis. Okay. What other bringing it up motion? Abduction, right? So if I abduct my hip, pubofemoral is on stretch. It's checking. Okay. The other thing that we're going to see, just like with the shoulder, is, and this is where, Sydney, the dislocations come in. What ligament is going to have to rupture or fail to have a certain dislocation? Okay, so if I have an inferior dislocation, then the pubofemoral ligament would fail, right? I don't know about you guys, that kind of sounds like a test question to me. Can I say it? Can you say it? Can you say it again? Say it slower. If the, I'm kidding with you guys. So think about the motions that each of these ligaments will check. Also, let's start layering on arthrokinematics, aka convex concave. When I extend my hip, what direction is the roll and what direction is the slide? Posterior roll, anterior slide. Okay, so if I have an anterior slide, my femoral head will push up against what ligament? Iliofemoral, right? So then, again, let's layer on a test question, right? Mrs. McGillicuddy gets catapulted out of a 4th-story window. Right, I know. It's so the 3rd year is actually like they had a whole section on Mrs. McGillicuddy and all the things she's been through. So Miss McGillicuddy gets catapulted out a 4th-story window, and she's doing like that big, like Tom Cruise in the first Mission Impossible, like that thing, right? And her hips are in extension. Her femoral heads are sliding forward because she's in extension. Iliofemoral ligament is getting pushed on. So if she's in extension and the iliofemoral ligament ruptures or fails, I will see anterior translation, aka a dislocation to the anterior direction of the femoral head. Right? Makes sense. If I go into abduction, like we said, what direction's the roll? What direction's the slide? Superior roll, inferior slide. Right? What ligament would get stressed? Pubofemoral. So if I have a patient and all of a sudden they want to do the splits and they decide they want to get it all in one shot, they're going to go into extreme abduction. Fair? Therefore, they're going to have extreme inferior translation of the femoral heads. If the pubofemoral ligament is not intact, they're going to have an inferior dislocation. Now, also think about how the acetabulum is made. In looking at the acetabulum I have up here, where is it most shallow? Probably down here, a little bit in the posterior. Like, it's pretty well defined up here at the top. And for very good reason, right? Because as I'm bearing weight, I need more contact area around the acetabulum, right? Around the superior aspect. I don't need so much contact area in the bottom. Makes sense. But this leaves me more susceptible and more likely to have an inferior dislocation. Make sense? This is also why we have those total hip arthroplasty precautions for patients, right? So what are those total hip arthroplasty precautions again? Internal rotation, flexion over 90, right? Don't do the splits. So then let's think about this. We have one more ligament back here, okay? And I'm gonna draw this in a dotted line, because this is going to be in the posterior aspect. And it's going to come off of my ischium. And this is going to be my iliofemoral ligament. My iliofemoral ligament is going to check posterior translation of the femoral head, right? So then give me the convex concave, aka give me the arthrokinematics that happen with hip flexion. Anterior roll, posterior slide. So this is why, if we think about it, this is why we have that hip precaution, no flexion over 90, right? Because what does the surgeon have to cut through in order to do that total hip replacement? Iliofemoral ligament. If they're doing a posterior approach, they have to cut through the iliofemoral ligament. You guys good? Posterior translation. So remember we talked about this last week. Naturally, there's a negative pressure, aka a vacuum at the hip. When surgeon goes in and does total hip arthroplasty, they cut through the capsule and they release all that pressure. So I've lost the vacuum and I've lost things like my iliofemoral ligament, depending on the approach, which is why these patients are so susceptible to things like a hip dislocation after a total hip arthroplasty. Let's think about this as well. The two motions we haven't talked about yet are rotation. So when I internally rotate my hip, what's the direction of roll and what's the direction of slide? Anterior roll, posterior slide. And that one makes a lot of sense because that lines up right with our total hip arthroplasty precautions. What do we tell our patients not to do? No adduction, no internal rotation, right? Because when I internally rotate, I'm taking that femoral head and I'm turning it right at the direction, right where they did the surgery. And just like we talked about, that acetabular cup, that acetabulum is a little more shallow in the posterior aspect anyway. Okay, that's why it's so important. External rotation, what's the roll, what's the slide? Posterior roll, anterior slide. So now my femoral head is pointed towards the anterior direction. Right? Big reason why when we have those patients with a total hip arthroplasty and they have an anterior approach, what are the big precautions? No external rotation and no extension, right? Because those are both going to cause an anterior slide. Okay, so you have to understand the anatomy, you have to understand the orthokinematics in order to understand those hip precautions. And they happen a lot. I can't tell you how many times I've seen patients, and this is the big one. Middle of the night, they use the restroom, drop the toilet paper. What do they instinctively do? Let me get that. They just internally rotated their hip, so you guys can see it over here. Right, so what do? They internally rotate their hip. And there it goes. So believe it or not, you guys will have to do a lot of coaching for this. Now, the other intrinsic ligament that we're going to see here, and Grace has a really nice picture of it. And I'm going to draw it. I'm going to draw it in black because I'm running out of colors. Understand that this one is intrinsic. It is inside. And this one's going to be called the round ligament of the femur. Sometimes you will see it called ligamentum teres, because remember, teres just means round. And the really interesting thing about this ligament is that this ligament is going to have a blood supply. That blood supply is going to provide some vascularization to the femoral head. But, and this is the really interesting thing about it, it's a branch off of the obturator artery. Okay, so again, think about potential test questions, right? If I have an occlusion to the obturator artery, then which of the following structures would receive compromised blood flow or would receive less blood flow? The femoral head would. Okay, because the femoral head is going to get blood, not exclusively, but a lot of it from that blood supply that surrounds and goes through the round ligament of the femur. Okay, so really important to know. Any questions on that? Obturator? Yep. Does it restrict any motions? The only motions it really checks is distraction. So literally the femoral head coming away from the acetabulum. That's another artery that gets snipped when they do a total hip replacement. Now the advantage is that because they're putting in titanium, ceramic, titanium alloy, whatever material they decide to use, that femoral head really doesn't need blood anymore. So it doesn't necessarily need a blood supply. How we doing, guys? Okay. I'll tell you what, let's do this. Let's go ahead and let's take 5 minutes, get up and stretch a little bit, and we'll move on to the next section. It's gonna check distraction.
Let's see what happens.
Ligament anterior. The trick is, and this is the advantage of working in healthcare, you live in the major metropolitan area and then you work in an outlet. Right? So like a lot, exactly. So like a lot of my coworkers, even though I work at Dunn, which is like 3 traffic lights, right? They all live in Fuquay or Raleigh because they're always going to your point against traffic.
I was living in Morrisville, right near RDU, but the clinics that I was working at were in Clayton, Connecticut.
Yep.
So, I mean, it was 50 miles, but it was only an hour drive.
Right.
An hour drive each way.
Right.
Traffic, it was always sitting still the other way.
Do I know everyone in my town? No. No. I don't live in Dunn. I technically don't live in a city. I live in the unincorporated Cumberland County. Yep. So I live outside the city limits. I live in a neighborhood. Like if you drove through my neighborhood, it's like, oh, this is a neighborhood, right? But I don't live in Fayetteville. I don't live in Linden. I don't live in any of those towns. I live in unincorporated Cumberland County. Now, which has some advantages and it has some disadvantages, right? So, like we get our water from Harnett County. We're on an energy co-op, right? So if you drive north on Ramsey, you're going to go past the South River Electric. So that's my electric provider. Private trash, right? So I pay a private company to come get my trash, which is actually not that bad. I'm on propane for my heat, and I got septic.
Taxes are low.
Oh, 1%. I'm on 1%, which is why I live there. Yeah. Now the weird.
Fire, specifically, we have to fire tax.
Mhm.
On top of taxes. So now we only have one.
Well, and that's a North Carolina thing to put all those taxes. Like this is the first state I've ever lived in where I pay taxes on my car every year. Yeah, we pay property tax on our car every year. And that's weird. No, it's not normal. Yeah. Now here's the thing. To register your car in Florida, it's $500 just for the tax. But yeah, it's very expensive to move to Florida. Once you're there, it's awesome. Like I'm telling you, my property taxes were low, all sorts of discounts to every amusement park you ever think of. I got free parking at the beach because I was a county resident. Like there's a lot of perks. Yeah. Oh my God. Okay, here's what I paid in Ohio. I paid all the federal income taxes, right? State income tax. That's everything about Florida. No state income tax. Yeah. So I paid all my federals. Okay. I paid my state. I paid my county. I paid my school district. I paid city tax, which was higher for me by 0.5% because I did not live in the city of Columbus, but I worked in the city of Columbus. So Columbus residents paid 2%, I paid 2.5% because I lived in the suburb. Yeah. And then property tax to the county on top of that at like 2.5% or whatever. I mean, it was crazy how much I paid. Yeah. I added it up, and I was probably close to 40, 45% of my income. Was going back.
But when your home value goes up, that means 1% of the state rate goes up. That's $3,000.
That's correct.
Just for voting.
Yeah, that's correct. Oh, insane, insane.
All right, guys, let's go ahead and get rolling again here. Let's get rolling again.